I'd love to be kept abreast of that. If there are things that we can do to support that, please let me know.
Great, thank you.
My second question has to do with hepatitis C. Obviously, we have many individuals who are living with HIV who also are living with hepatitis C. And while I think we were all happy to see an investment in hepatitis C treatment in the budget, I think many of us were shocked at the price tag, particularly for a drug that is going to cost $1,000 per pill, $85,000 per treatment, that will result in a $300 million increase as proposed by the governor. And just to put that in perspective, last year the state legislature, through its negotiations with the governor on the budget, increased the budget by about $500 million, $500 million. This year it's being proposed for one drug, $300 million of an increase. In the staff report, it referenced the fact that ADAP programs were able to negotiate a rebate on one of these drugs, although the specific amount of the rebate is still unknown. I've seen some reports in the press that there is a 46% rebate. Could you talk a little bit more about what you know of that rebate and where that conversation is going?
Sure. So the California's ADAP program works with a national negotiating body called the ADAP Crisis Task Force, which negotiates drug pricing for all ADAPs across the country. And our ADAP program gets what's called 340B pricing for ADAP drugs, which many other public payers do as well. But then on top of that, works with pharmaceutical manufacturers to negotiate additional rebates below 340B prices. We've been very successful in negotiating sub-340B prices on many of the antiretrovirals, and the ACTF is working on that for the hepatitis C drugs as well. So that referenced the fact that the ACTF announced, I think it was in the beginning of January, that they had worked with AbbVie, which is the maker of one of the newest drugs, to successfully negotiate a substantial decrease on the price of that particular drug.
So at this point, no news on, for example, Gilead's Sovaldi, which I know is the drug that has caught a lot of policymakers' attention.
So Gilead has not yet negotiated a lower price for ADAPs across the country for Sovaldi or Harvoni.
But as far as you know, that conversation is ongoing?
That conversation is ongoing.
Okay. Seems like there are other staffers that might have some perspectives on that.
Jamie Metallica, Department of Finance. There was a news announcement that came out mid-February from Gillette in regards to Harvoni and Sovaldi. And so while we don't have as much information as I'd like to be able to share, I do know that they did make a statement that they were looking at about having the cost of their $85,000 treatment. So, and that was a press release that came out from them.
Okay. I
Yeah.
think
So again, each payer source has different pricing, but yes, they did put out a statement that they were lowering their prices.
Right. I know that there's a lot of interest in understanding these skyrocketing drug prices and what's really driving them. So as you get more information, my office would love to get it.
Great, thanks.
Ms. Harbison, I didn't give you a chance. Did you have anything else from Finance, not just on this question, but in general? Good. Mr. Martin, anything from LAO's office on this presentation?
Sean Martin with the Legislative Analyst's Office. We've reviewed the AIDS Drug Assistance Program estimate, and we're not raising any issues at this time. We'll look at it again at the time of the May revision. Also, we're not raising any issues with the budget change proposal.
Thank you. Questions from the committee? Ms. Grove.
Thank you, Mr. Chair. I'd like to follow up on that Gilead's proposal for Sovaldi. And the reason why I'm asking is I look at it from a business owner perspective. First, we had the last committee hearing where they were saying that, $300 million, that's only going to cover 3,000 people. And we were talking, I believe, with the Department of Corrections or who, that oversees that. It seems like there's more than 3,000 people in our prison systems that are going to need this drug, and at $85,000 each that we as a state are going to be responsible for. I started researching some of the stuff on the company itself. I am not about limiting profit. I'm about free market. But I do have a question that if somebody paid $11.2 billion for a company and has already had an ROI and increased sales by $12.4 billion and paid back that investment that they have, why are they still charging $85,000 for the treatment? And again, I'm not trying to say I'm willing to limit profits, but there has to be some type of reasonability and negotiation with the state or pharmaceutical companies that like I said, it's public knowledge. They paid $11.4 billion for the company, and they've already had a return on investment of exceeding $12 billion. And this is something that will be carried on for the lifetime of people's expectancy to have this particular disease. So I just wanted to know if the state was doing anything regarding the negotiations based on information like that.
So I can't speak about other areas of the state because my expertise is only in the ADAP program. But like I said,
hepatitis.
Yes, exactly. So we do have a significant number of people who are co-infected with hepatitis C. But like I said, we work with the national negotiating body who negotiates prices for all state ADAPs throughout the country, and we have been actively trying to negotiate a better price.
So if you're successful, because I didn't hear that in the last committee hearing with that department head that said that they were negotiating a better price. I didn't, and I could have not been present in the room when they said they were doing that. If you're successful with ADAP in your state, your role in the state, is that something that you would share with other departments so that they could actually negotiate that deal as well? Is it shared?
Yeah, hi, Member Grove. I think your comments are right on point about the ROI and about how much money they've already gotten back. And I think that's what the market pressures have come out by them coming out and saying that they're looking at their pricing.
Okay.
And you're right. We, as a state, want to make sure that everybody's, enjoying the benefit of a reduction in prices if we're all buying the same drugs.
Okay.
So our work group is looking into that as well.
Thank you. Thank you for your...
Just one question. First of all, thank you for all that you shared and what you do. We know that it's the classic case where the need is greater than all the resources that are needed, and thank you for serving our public. My question really is about the question of drug pricing in the work group and however else this happens. What is the mechanism for the public and for those who are being treated to be able to have input in the conversation around pricing? Is there a mechanism, and if so, what is it?
Yeah, Chairman, I think that's kind of one of those questions that go back to, like, a lot of the price rebates come from the federal government. It's negotiated on a national level. ADAP is part of the national ADAP program that benefits from that. But also, the Medi-Cal program as well, as far as Medicaid for the different states. I think that process would be here in the budget hearings, maybe through policy as well. But it's mostly market pressures for pricing of those drugs and the cost of the R&D research and all that.
The work group that you referenced in the last question, could you say more about that? And is there a place for citizen participation and for those who are actually treated to have voice in that process?
Yeah, we do. Right now the working group is getting started and established. They're going to start putting together a kind of like a what are we doing? Why are we here? What are we looking at? And then after about a month of putting together a proposal, then they're going to look at having stakeholders come in and then get their word and get their information and best practices or information that they can share with the working group so that we can come forth with a better proposal to the legislature.
Thanks. We'll probably have other questions, and you can sit at the end next time. Thank you. We appreciate your flexibility, but we might have some other questions for you. We want you to stick around. We have a few recommendations here, and I'm sorry, public comment. Is there public comment? Each speaker will have 1 minute, please.
David Ford, Noteware Government Relations, on behalf of Gilead. So a couple things. When a company like Gilead is negotiating with the state government, it often puts us in a bit of a tricky position because those negotiations are proprietary. But the hearing last week that Ms. Grove referenced, just so you know, the next day, on February 24th, Gilead actually completed their negotiations with Medi-Cal to add Harvoni and Sovaldi to the Medi-Cal formula. What, as I say, it's proprietary, but what I understand are very steep discounts. And so that process with Medi-Cal has been completed. We look forward to the conversation with this interagency working group on how that can be handled in other sectors. I would also add what's happening in the private market is, of course, that now that there are other companies that are entering this space. Competition, we understand, is leading to some pretty steep discounts in the private market. I don't think there's anybody still paying the quoted prices on Harvoni and Sovaldi. Thank you for your time.
Thank you.
Good afternoon, committee chair and members. My name is Courtney Mulhern Pearson. I'm here from the San Francisco AIDS Foundation. And I'm also here from the California HIV Alliance. I just wanted to thank the committee staff for a really thorough analysis of this program, and thank you for your clarifying remarks. We wanted to just again highlight, and thank you for highlighting the safety net care pool funding ending, and just to clarify on when this funding was initially put into the program, it was replacing state general fund, and it's functioned like state general fund so that it allows for more flexibility. Some of the rebate funds come with restrictions on how that funding can be used. So we're concerned about decreased flexibility for the program with those funds ending, and we also support the, what's been laid out in the analysis around concerns about removing this funding, and we'll be coming back with proposals about ways that we would like to see state general fund reinvested in HIV in the state. And then also we would support the positions being added to the department. We also have some proposals around staffing needs that we have seen and would be interested in exploring whether any of these positions could be potentially redirected to help stabilize some of the programs that have been discussed here today that are experiencing growing pain. So we will be coming.
Stand up because I'm going to have this stuff. Thank you.
But we will be coming back in April with a more fleshed out proposal. We've already shared with your staffer and with your staff as well. So we again would love to see more reinvestment and potentially discussing ways that those program staff could be redirected, or some of them could be redirected to help stabilize programs.
Thank you.
Thank you, Mr. Chairman and members of the committee. Maureen O'Haron, representing AIDS Project Los Angeles. I just want to echo the comments made by my colleague from San Francisco AIDS Foundation that we would like to explore with the Office of AIDS how to get more staff over to ADAP and OAHIP. As the program's caseload has continued to increase, but staff has remained flat, and there is need to shift positions over there. And again, we would also raise the concern about the loss of the safety net care pool funding. As Dr. Marks said, some of these programs are just getting off the ground, and we're going to be losing funding at the end of October of this year. And in 2009, we lost $84 million out of Office of AIDS programs, and it was a devastating blow to all of these programs. And to lose yet another source of funding is just another reason why we can't get to zero. So, it would help, enjoy your help. Thank you very much.
Thank you. Additional questions from the committee. Mr. Chu, did you have a question? Ms. Grove.
Thank you. I don't know if anybody in the room can answer this, but I am curious about the statement that was made just a few minutes ago from Gilead. So I guess it's proprietary information on the cost negotiations. Is that available and available to the Public Open Records Act? Does anybody know that? Finance, anybody? Is that going to be available to anybody?
I apologize. Sorry.
So I don't know if anybody can answer this, but there was a statement made that said that they had negotiated on the 24th a deal based on the hearing that the chair had, that there was a deal negotiated with Medi-Cal, I believe, for a reduction in costs or a significant reduction in costs, but it's proprietary information. Is that information available under the Public Open Records Act?
Yeah, I'm not exactly sure if what resulted from that meeting would be available under the PRA Act, but I can definitely find out for you. I can go back and search.
And is that something that you participate, not you yourself, but finance participated in?
I actually do not know the answer to that question, but I will find out if finance was part of that and get back to your office.
Who is a part of the negotiation? Can somebody tell me that? Anybody?
I don't know if DHCS folks are here today.
Okay.
I do apologize.
No, that's right. Thanks.
But I can definitely get it.
Appreciate it.
Mr. Martin.
Thank you. Our office does not have access to that proprietary information. However, I recall reading a Bureau of State Audits report from the early 2000s, so this would be over a decade old, but I believe they may have access to that proprietary information. But it's very closely guarded by the pharmaceutical companies because it's sensitive pricing information. Typically, when they negotiate those discounts or rebates, they write into the contract that information will not be widely publicly available.
I would just join in our colleagues' request for that information as well. I think from my perspective, what we have heard is that the price for these drugs are justified by the costs. And if that is indeed the case, I would hope that we could at least see some information that gives us confidence that is so, that the costs are somehow commensurate with the prices. Because if they're not, then then maybe those prices should not be as high as they should. And I think for many of us, for policymakers, we were all perplexed at the fact that we were talking about a $1,000 pill. But now I understand that just within the last few weeks, that price may have dropped by 46%. And so really understanding that is something that I'm curious about as well.
We can definitely get more information for you as well. Same information as well, yes.
And I would certainly mention to any representatives of companies or others that are here, if you want to provide that information to us directly, we'd be happy to take a look at that.
Ms. Grove.
Thank you. And again, for the record, I'm not interested. I'm a business owner, and I get it from a business perspective. I'm not trying to detour or stop free market and fair competition, but it is a single source supplier. Am I correct, or is there another supplier?
Well, there is competition as of right now. I believe Abby V, maybe Dr. Mark can speak more to that, but there are other competitors for Hep C treatment.
Okay.
Well, yeah, I mean, specifically, there are several basically equally efficacious hepatitis C treatments available now, some made by different companies, but each particular drug is only made by one company.
Okay. So, and like I said, it's this particular single source supplier, I get it. And I get that there is a significant investment that has to go into R&D and everything to make these drugs available. And, $12 billion is not pocket change. I get that they have to do that. And they should be able to price a product to get a ROI, return on investment, for what they have invested and to make a profit. I mean, that's why people are in business, right? To employ people, make a profit, I get it. But there needs to be some reasonability, especially when it comes to state issues, and I believe the private sector as well, especially if it's a single source supplier. So I'm not trying to, I just want the record to reflect that I'm not advocating against business. I just want some answers.
I think the record reflected that, although I was excited by your advocacy for making sure that state government is not charged the highest rate to support those we serve in the public. Mr. Chu, did you have anything else?
And I would also echo Member Grove's comments as well. As someone who was a former business person, I completely appreciate that when a company invests and does research and development, they ought to get a fair rate of return. The question is, at a time when we're seeing skyrocketing drug prices, when we're talking about a potential $300 million increase in our state budget for one drug for 3,000 patients at $1,000 per pill, $85,000 per treatment, are we getting a fair price? That's really, I think, what we're trying to get at as well.
We appreciate the continued information and look forward to that. Staff is recommending that we hold open the ADAP estimate until after the release of the May revision. Without objection, the committee will do that. The staff is recommending approval of the requested ADAP rebate fund expenditure authority of $536,000 and 5 positions to centralize ADAP eligibility verification. Is there a motion?
I'll move that.
A second? A second. Chu motions and Grove seconds. Roll call vote.
Thurman?
Yes.
Bonta? Chu?
Aye.
Grove? Jones?
So that has.
By a count of 4, motion passes. Thank you, members. Moving on to issue 3. Thank you, panelists. An update on the program estimate for the Women, Infants, and Children program. We'll welcome Connie Mitchell, Deputy Director for the Center for Family Health, Christine Nelson, Chief, Women, Infants, and Children Division, the Center for Family Health. And we'll have updates from the LAO's office and finance. Ms. Mitchell, would you like to begin? Welcome.
Thank you very much. So I'm Dr. Connie Mitchell. I'm the new Center Deputy Director of the Center for Family Health, and this is my first hearing. So maybe the same thing for some of you, I'm not sure.
Welcome.
Thank you. I just thought I'd just in general describe what our center does, not getting down into a lot of programmatic details, but just to give you a framework. We have 3 divisions in the center. One is WIC, which we're going to address first, and then Genetic Disease Screening Program, and then our Maternal Child and Adolescent Health Program. But we don't think of it in terms of division work. We think in terms of how do we get kids off to a healthy start. So, and that's all kids. How do we prepare girls and women to be as healthy as they possibly can so that if they become pregnant, they're ready to hopefully carry to term a very healthy baby And so and then we also think about what happens after pregnancy. So we think about before becoming pregnant and maximizing the health of women and girls, during pregnancy, and then after pregnancy, how do we help that young baby to get off to a great start, school readiness programs, home visiting programs. So that's how we organize our work. And so each of our divisions then contribute to that concept. So I thought that might be helpful to you kind of philosophically to know who we are. So the first issue is in regards to our WIC program and walking you through our program estimate. And I have with us today Christine Nelson, who is the division chief of WIC, who's going to walk you through the estimate and answer the questions that you have in it.
Good afternoon. Thank you for having us here today. So I'll give a brief overview of the WIC estimate. We did do a change in our methodology for this estimate. In previous years, we have grouped all participants in one as looking at the statewide numbers, and we also calculated a cost per participant as an average for our total population. But in this estimate, we broke that participation down to different categories. So we're looking specifically at pregnant women, postpartum women that breastfeed, postpartum women that don't breastfeed, infants, and children, which are children categories from the first birthday up to the 5th birthday. And what we've seen is the retention is different for different categories, and certainly the cost per participant is very different for different categories. So we thought it was very helpful in this estimate to change how we lay everything out so that both we can study our population differently and that you could see and understand more about the program that way. So we have, historically, we've looked at past participation and a rolling average change in participation to project the future. But in this estimate, we changed that and we are looking at the birth rate. So we have provided a birth rate from the Department of Finance, and we're applying that to prior year to see what would the change be going forward. And that the birth rate is, of course, very closely tied to our pregnant women category, postpartum, and infant category. And this year we're still using it for the children category, but we're looking at other options in the future to see how we can project the children caseload going forward. And as I said, we are also projecting the cost per participant, the food cost per participant, by the 5 different categories going forward. And then we take the future participation for each category times the cost per participant for each category to project the total cost for that participant category, and then add the 5 together, and that is our total program costs. So your staff have done a nice job highlighting the numbers of our estimates, so I'm not going to walk you through all those details, but I did want to point out that we are federally funded, completely federally funded, and we do still continue to have sufficient funds to fully support the program and even some room for growth. So there's no concern about having to make any kind of policy changes to change participation going forward. I would like to highlight 3 programmatic areas and some recent changes and future things that we're doing in the program. First is vendor management. And by vendors, we mean the grocery stores that we authorize in the program. Second, participation, so the clients that we serve. And third, getting ready for EBT, the electronic benefits transfer. So we are moving forward on that. So first, I'll address vendor management. And over the past several years, we have developed and implemented significant changes in the program to both contain food costs and improve program integrity. And while these changes were being developed and implemented, the USDA, U.S. Department of Agriculture, which is our federal funder, implemented a moratorium on adding more vendors to the program. So over this past few years, we have looked at the full spectrum of our vendor management, from how stores are authorized to the program, what foods we authorize on the program, how we monitor the vendors and ensure appropriate oversight, and then how we reimburse the vendors. So we implemented through regulations new changes to authorization criteria. We changed some foods that we authorize in order to reduce costs but maintain the nutrition benefit to the family. We have made internal changes to our organizational structure and our staffing to improve and increase our vendor oversight. And then last June 2014, we implemented our biggest change in regulation, which is how we group and reimburse our vendors. And when we implemented that change last summer, the USDA allowed us to begin to phase out the moratorium. So from June 1st of 2014 through January 31st of 2015, we were able to authorize 271 new stores to the program. And that brought our total as of January 31st to 4,270 stores authorized on the WIC program. And on February 1st of 2015, we did get approval from USDA to fully lift the vendor moratorium. So there is no moratorium in place any longer. And since February 1st, we have received 80 applications for new vendors. So we're going through the process to review those applications, train the grocery stores, do on-site reviews, and then, as appropriate, would authorize the stores to join the program. I'll talk a little bit about participation. Each year, the USDA publishes a report on describing the WIC eligible population nationwide and the WIC people that actually receive WIC services. And they compare the actual participation to the eligibles to determine what is called the coverage rate. And nationally, the coverage rate for the WIC program is 63%, meaning that 63% of people that are eligible actually receive the services. But I'm very pleased to say that California continues to have the highest state rate in the nation. We serve 82%. So we're 19 percentage points above average. We're very pleased with that. But what we always want to do better, and we want to know more about what we're doing. So we're doing an analysis to take those statewide numbers down to the local level, and also, again, taking that total participation and breaking it down by the different categories: pregnant women, postpartum women, infants, and children, and understanding what are the nuances. And there certainly are differences in the different categories. We've seen in California that we do very, very well with postpartum women and infants. We serve more than 90% of those that are eligible. And we also do very well with pregnant women, and most of the pregnant women that come into the program come very early in their pregnancy, which is great. But the one group where our coverage rate is the lowest is children. And that's understandable. As children get older, they have more options for Head Start programs, preschool, and other opportunities for nutrition services. So that's the group that we really want to focus on going forward. We also have seen, we've broken the statewide numbers down to the county level in many areas. Some small counties, we're not able to have a county level data. We have some groupings of counties, but we have identified some areas in the state where they do have opportunities for improvement, and other areas that are doing significantly well. And so we want to work closely with those that might need a little help, and also those that are doing very well, to understand and share their best practices. And we continue to want to focus on the children, and how can we support families and help them to know what the benefits are of WIC. It's not just a food benefit, but we provide nutrition education and referral to health care and other social services. So there's really a wide range of services that we offer there. And lastly, I'll give you an update about EBT, our transition to moving from our paper checks to electronic benefits transfer, which we're very excited about. The USDA has mandated that all states move to EBT by October of 2020. There are currently only 9 states that are already there for EBT for WIC. We are partnering with the California Department of Social Services and Health and Human Services on a request for proposal for an EBT processor in California. Department of Social Services already has EBT for SNAP, of course, and it's time for them to renew or do their procurement again, so we've jumped on the train with them, and we'll be doing a joint procurement. Per USDA guidelines, though, we will continue to have 2 separate cards, since it is funded as 2 separate programs nationally. We're sharing a lot of resources and planning together on the RFP, but we will have two different cards. And then in order to roll out EBT for WIC, we do have to change the IT system that we use in the state and in the 650 WIC sites that we use for enrollment and case management and maintaining all the foods. We have to add all these UPC codes for different foods that will be authorized on the program into our database. So we will be replacing our IT system. We are not building a new system, but rather we are bringing a previously approved, USDA approved, already built system to California. We will have to make some adjustments to make sure that it meets the current USDA requirements and that it meets the size and capacity of California. We're working closely with California Department of Technology on that procurement as well. So I appreciate the opportunity to speak to you today and highlight some of the things going on in the WIC program. Thank you.
Thank you, Dr. Mitchell. Did you have anything else?
On this particular?
On this
no.
one. Okay, well, we'll welcome you at the next panel, too,
Yes.
And maybe for some of the questions that we have. Ms. Harbison, we'll let you go first this time. Anything from Finance?
Thank you. Thank you, Mr. Chair. Kimberly Harbison, Department of Finance. Nothing from us today.
Thank you. Anything from the LAO's office? Thank you. Any questions from the committee? Committee members? I do have one or two. Ms. Nelson, Chief Nelson, you mentioned some food changes in what a recipient can use the WIP grant to purchase. Could you mention what things have been added or changed or deleted from what's allowed?
So the change that I mentioned was specifically to our cost containment changes. The one major change that we made was in baby formula, or excuse me, baby food. Baby food, we're very familiar with the jars. Several years ago, it came onto the market pouches, and so we disallowed the pouches from the program. It's the same food content, but twice the cost. So there's no change to what the participant receives as far as nutrition benefit, but we saved over $1 million a year in just making that change.